in between this adventitia and this is the plaque burden, or you can call the atheroma. Anything between these yellow line and the blue line is the plaque burden. And now when you are going to treat the plaque, or it is needed to treat, is the 60% of plaque burden. If it is 60% or more, then you have to treat that. And what is minimal luminal area is, that's very important, as here it is shown that this is your minimal luminal diameter. And as we mentioned before, that if your minimal luminal area in an epicardial vessel is less than 4, you need to treat that in non-left main. In left main, the cutoff is 6 millimeter square. And it is very well correlated with an ischemic FFR value of less than 0.80. So this is correlated with FFR as well, or with an iFR of 0.90. Now, we can get from this image the plaque characteristics as well. Like that can be very calcific, that can be fibrotic, that can be a soft plaque. So we can get that from the IVUS. And that's very important for procedure planning, because I will show you one of the case very important, that if you don't have a plaque modification, so your short-term and long-term events are adversely affected, because you will have an underexpanded stent, and that will lead to stent thrombosis and ISR. So this is how this appears. This is your catheter. As we already said, there is a minimal plaque here. There is a lot of plaque here. And this is what we see is an underexpanded stent. And as I have already mentioned, is uses of IVUS is very important to plan which diameter of stent you have to take. You can take the length of it very precisely, and diameter, as well as your post-stent dilatation. You can plan that as well, looking into the different distal reference diameter in the proximal. And in complex PCI, it's very important tool for a left main or for calcification. So definitely IVUS has a very key role in optimizing the procedure. So I will switch to the case example. So this was a very young gentleman, less than 40 years of age. He had an acute anterior wall MI, and he referred after a day with ongoing pain to our outpatient. Then we bring him into the cath lab. We'll do their presentation. So angiographically, this was giving the appearance of a moderate disease, but when we did IVUS, there was a calcific nodule as well as, so this was a 40-year-old gentleman who was with ongoing pain. And can you just play this? Yeah. So look at this proximal LAD. Here it gives appearance of a moderate disease. Next, please. Plate. So go back to that. Plate. So here, see, what giving is the appearance is there is a branch coming up, but in multiple views, it was giving as a moderate eccentric plaque. And now look at the IVUS image. Next, please. So here, see, look at this was that eccentric lesion which was giving the appearance in that caudal view. And it's an arc of calcium. And next, please. So I will just quickly go through it because we have other cases as well. So here, this one is the nodule. Next, please. Next. So here, look at this, how we have taken a stent, we have deployed, and we post-dilated that with a larger balloon. The stent was 3.0 and post-dilated with the 3.5, but still, see, there is a lot of underexpansion. So the key message from this was that no matter whatever you do, you can't expand if there is a nodule. So you need to do cutting balloon or road ablation, that's important. And you have to upgrade the burr size according to your vessel. Next, please. Can we play this? So this was the post dilatation with a 375 INSI. And we didn't want to disrupt everything. So because this was an acute STEMI, and that's why we were on a, not going that aggressive. So we had a good angiographic result. Next, please. वो जो pictures थे वो दिखाए थे वो जरा दिखा दें. So I was also telling you the underexpanded part of the stent. And you can size your vessel, you can have a reference diameter, your proximal, and you can upsize accordingly. Can we switch to the other presentation, I think? जो दूसरी presentation FFR वाली. One very interesting case was we did IVUS as well as physiology, so I want to show that. Now in this, Abdal is here, so these tools, as I have already mentioned, is very important. And another part which this machine has is physiology. And physiology is very important because why we all treat the coronary artery. Because we treat the coronary arteries when the myocardium is ischemic and it is causing pain. But for that ischemic, you need a threshold, which is reducing the substantial blood flow and causing pain to the patient. So the aim of our treatment, either bypass or PCI, is to relieve the symptom as well as to treat that ischemic myocardium for future events as well. So for that matter, we in our own practice, we do come across the lesion, which are not critical, which are moderate. So then we need other tools. And in other tools, there are non-invasive as well as invasive assessment, which is the functional assessment of that particular vessel. In non-invasive testing, what we do is overall picture. If your overall myocardium is ischemic, you are not really sure. So that's why physiology has a role which will precisely tell you that this particular artery is ischemic and you're gonna treat that. So we all are aware of the role of physiology, and there is resting flow ratios as well as the fractional flow reserve where we have hyperemic indices. So all these are validated, tested, and it has a key role. There is a lot of data on it. It's proven benefit. So that's why we have to incorporate physiology. And mind you, I will just show you one of the case, very interesting, is sometime it's so valuable that you can prevent to put in a stent in. And that's very key to a stable plaque, which is non-ischemic. So it has got a key role. Not only we are need to just see the lesion and just stent it. Sometimes we don't want to treat that if that is not ischemic. Because 15 years, there's data, 15 years, even free survival has shown if it's non-physiological significance. And we know from a lot of trials that the annual mortality, if it's less ischemic, is very low. So that's why it's very important to incorporate these tools into the practice. So what we are doing at our center, we are doing a lot of resting, the iFR and DFR. Is a diastolic flow ratio, and the beauty of that is just you put a pressure wire across the lesion, and this gives you the proximal and distal pressure. And if it is more than 0.90, then you don't need to treat that. So it's make your life easy. You just you avoid some, you have a time bach jata hai. And another thing is that you don't need to inject adenosine. So, and there is a lot of data on it as well. So iFR is a logical flow on the FFR. iFR isolates a specific period in diastole known as the wave-free period. When a stenosis is flow limiting, proximal and distal pressure over the valve-free period diverge with an iFR value below 0.9, suggesting flow restriction. You don't need to have any gradient across that. But if there is significant stenosis, there is gradient. So there is no need to give adenosine, and it's very easy. So we have a case. I will go to that. And these are the steps how to do it. You connect the equipment correctly. You zero it, both your guide and your disc pressures. And you just put the wire in. You equalize the pressure. And then you cross the lesion. And then you measure your pressure. And so this is about the FFR. You give adenosine, and then you take your pullback pressures. One word about this, you have to do it correctly. That's very important. The introducer needle, you have to take it out from the guide. There are a couple of pitfalls like damping of the pressure if your guide is deep into the ostium. So then that will have a wrongly FFR value of ischemic. So that's very important. If you have a, suppose, can we go back to, this is available, this presentation? So, वो वीडियो ज़रा भी दिखा दें, इसके अलग मैंने दिखाया था, उसके साथ इमेजेस भी थे. Yeah, but the dose is different. For intracoronary, you need to give 100 to 140, and for intravenous, at least 400 microns. That's important. The dose is different. It doesn't make any difference. We do IV. Yes. No. It's not necessarily. यहाँ पे नहीं आ रहा. ये minimize कर ले तो वीडियो. अच्छा, this is very good case. So this was a lady who is hypertensive. He was referred from another center by a surgeon as well as by a cardiologist for assessment of left main. And she had a previous stent placement 3 years ago, or rather 5 years ago in 2017. And she was with symptom, angina clause on exertion. And look at here, if you see it. So what do you think on this ostial left main? What are take on this? Anyone who want to just say a couple of words about it? So this is the left main. Yeah, perfect. So what you're gonna do next with this patient? Perfect. Can we go to next? Next, please. वो जो images दिखाए थे. अच्छा, we did IVUS to it. The MLA was more than 6, and the plaque burden was just 40%. So it was not qualifying the indication to intervene on IVUS. Then what we did, we were right there. She had angina. We thought that we should do physiology as well. So we did physiology. This is the pullback of iFR from the LAD to the left main. The guide was... It was normal. Perfectly normal. She was referred by the surgeon as well as, because she was referred by another surgeon cardiologist for a cabbage. But the surgeon has a conservation, and then that he referred back to him, and he referred to us for further testing. ये नहीं, वो picture दिखा दे वो ये वाले. So this is an iFR we did, and it was non-ischemic. So we had a 0.90, and from एक और image थी. From circ to left main, it was 0.95. So then we didn't stent that. We reassure with the medication, and the patient is doing well. So the basic take home is from these things is that really it changes the way we see, because in geography, as I have already told, if I have not told, I repeat the words, is has limitation. It's a 2D structure. And what in geographically appears to me, maybe I take it severe, and that may not be. So that's why in certain cases we need MH and we need these tools. So, and also for optimization of the procedure, both has role. You put a stent in, you do post-stent run, and you see the stent expansion. You can have, if you can make sure there is no edge dissection, proximal and distal, and your stent is well expanded and well opposed. And in a similar fashion, we have data about physiology post-PCI. If your iFR is more than 0.95, your event risks are very low, both short-term and long-term. So thank you very much for participating in this part. And we can still go to that. We can have some demo. If there is any question, we can take that. And one thing is that in a hospital, we can have a good relation with the industry to bring in these tools. That's very important. And I would say to the Boston that the IVUS catheter, the rota, and these things has to be prioritized for a center which is doing high volume, and they have to support others as well. This is how the practice has to evolve, and these are very important tools, honestly speaking. Ji, please.
So, what's your experience regarding the comparison of IFR and the FFR? Sorry, qFR and the FFR, especially in the
Sorry, we don't have a qFR. We don't have a qFR. We don't have a.
practically don't use it.
Yeah, we are trying about it. We are looking for it, but we don't have qFR. But there is a lot of data from Japan and couple of the center from Singapore. They are doing qFR, and it's very good. And it's very simple as well. That doesn't need anything. On angiography, you do that. Yeah, that's the beauty. So there is data on it, but we don't have. But we are looking for it. Maybe in future we can have that.